The Genuine Article. Discussion and commentary based on articles from JACC.
Hello, I'm Tony DeMaria, the editor of JACC, here with another edition of The Genuine Article. Now, the American College of Cardiology has recently gotten together with a number of other organizations, including the American Heart Association and SCAI, and developed a document that lists appropriate use criteria for various diagnostic and now therapeutic procedures. Now, we have an article that's up online that lists these AUC, appropriate use criteria, for cardiac revascularization procedures. And this is the very first of these documents that addresses therapeutic rather than diagnostic procedures. And we have this morning to discuss this with us Dr. Manesh Patel, who's assistant professor of medicine at Duke, and he was the chairman of the writing committee of this. So tell me, Dr. Patel, maybe we can start by a general statement of how these appropriate use criteria differ from the standard guidelines.
Thanks for having me. I think the standard guidelines often take a disease entity such as heart failure or chronic stable angina and do an extensive literature review for all the available evidence and then provide guidelines to both clinicians and patients. The appropriate use criteria, I think, are meant more to be respective of our clinical scenarios that we see in everyday practice. There are often areas where we don't have evidence, yet we're practicing, and what we're trying to understand is the use of a technology reasonable in that scenario. So as you stated, we started with diagnostic imaging to understand if diagnostic imaging around the country for different clinical scenarios where we may or may not have evidence is reasonable as we practice in medicine. And our concerns have been in the past that there are opportunities for improved care where there may be an underuse of a technology, maybe overuse or misuse. And so appropriateness use criteria are to hopefully give us a standard amongst ourselves and patients to look at our care patterns.
Sure. In terms of revascularization, how many scenarios specifically did you consider?
We specifically considered 180 scenarios with two questions in mind. The first being, is it appropriate to do any form of coronary revascularization, whether it be with percutaneous intervention or bypass surgery? Many times patients just want to know, is there a benefit towards doing anything to get more blood flow to my heart? And then the second, and the last table in the document for some higher coronary artery disease areas and symptomatic patients, we look into methods of revascularization.
Now, 120 situations, or 180 or 200 even, probably doesn't cover the whole spectrum of variables that can exist in individual patients.
You're absolutely right, and that was one of the challenges for the writing group. What we found, and I think this was helpful to us, is that we were able to develop a framework for thinking about coronary revascularization. I think this framework will be helpful for both patients and clinicians, and the framework really has four sort of pillars. The first is, what is the symptom status of the patient? Is it an acute situation? Is it a chronic anginal situation? And how much do the patients have symptoms? The second pillar is what degree of ischemia is present, or how much blood flow is not getting to the myocardium. The third is what is the patient's medical therapy? How good or how not good on the anti-anginal therapy are the patients? And finally, we sort of review all of these and ask patients a little bit about the risk of revascularization. So their symptom status, degree of ischemia, anatomy, meaning how many of the arteries are blocked, and then medical therapy. So four pillars of the clinical scenarios. There are extremes in care, and we deal with them here as you do every day. Older patients with many comorbidities that may not be represented in the scenarios.
Yeah, and as I read, you divide generally into 10 categories, of which categories 7 to 10 are kind of straightforward positive indications for revascularization. Categories 1 to 3, categories where revascularization probably isn't indicated, and then those problematic ones in the middle. Now, how did you come by the category for each of these clinical scenarios?
Yeah, thanks. So what we did was we first defined what an appropriate revascularization should be defined as. And that in the document is defined as a revascularization event that leads to improved health status for the patient, meaning they feel better or they live longer, so that the risks are less than the benefits of the revascularization. We then, as you said, had this scoring system where 7 through 9 is felt to be appropriate, 4 through 6 is felt to be uncertain, and 1 through 3 is felt to be inappropriate. We have these clinical scenarios formed, and we had a technical panel, 17 members of the community that included interventional cardiologists, bypass surgeons, payers, general cardiologists, general medicine physicians who may be referring patients for revascularization. This technical panel reviewed the indications and the available evidence, scored them at home, and then met each other in a face-to-face one-day meeting where everyone could speak their mind and speak their view of the evidence. They then went back and re-rated the indications, and that helped us get to our final score.
Well, I think this is going to be a very important document. It's really the first in what I anticipate will be many, and it will be utilized, I would anticipate, as we see individual patients and make sure that our own decision-making is, in fact, conforming to that of this panel of experts drawn from multiple disciplines. So thanks a million for your efforts in this regard, Dr. Patel. We'll read this manuscript in JACC with a great deal of interest and look forward to additional ones to come. For the Genuine Article, I'm Tony DeMaria.
Have a question or comment about a CVN story? Send us an email at cvnfeedback@acc.org.